The revolutionary part to me as a cardiologist is the ability to create a 3D map of the heart, which EKG really can't do.
Dr. Bender, thank you so much for joining us today, and really excited to talk about your work and the excitement for Sandbox's magnetocardiography. But before we jump in, would you be willing to share a little bit about yourself and your practice so that our audience can know who you are?
Yeah, so I am, as you said, Dr. Jeff Bender. I'm the chief of cardiology at Mount Sinai West and the medical director for the health system for the network. And I do a lot of work both on technology and AI, as well as leading a lot of our clinical operations. And happy to be here. Tico?
Thank you so much, Dr. Bender. So maybe understanding a little bit about the history that you have with SandboxAQ, how did you what's your exposure to the need around better options for ACS patients?
Yeah, I mean, so as a cardiologist, we live in this space. And, one people don't realize is that when someone has a heart attack, it's pretty obvious most of the time. They have those big things you see on TV, ST elevation, MI, those are obvious. It's the ones that we don't know about that scare us, that keep us up at night. And so, we have about in this country 6.5 million admissions to the ER, for chest pain. And the vast majority of them end up ruling out and they spend time in the hospital. So we spend a lot of time and resources, both on the scientific end, but on the operational end, trying to figure out what are the best pathways. And I've been on hundreds of meetings for pathways and new options to rule out patients, new CAT scans and stress tests. But at the end of the day, we still have these patients and they live in what we call the gray zone. And the gray zone is really that magical place where we don't know what's going to happen to the patient. And we spend about $3 billion a year. $3 billion a year, that's probably excessive on ruling out chest pain, when if we could have a direct pathway, we could really decrease that cost and time greatly. So to me, the problem always existed, and we've always been looking for solutions. But, when I met Jack and he proposed it, I didn't think it was real, but here we are today.
So you mentioned that many of those patients who come in with chest pain, not the easy rule-ins or rule-outs, those gray zone patients, they consume resources and beds. What does that mean to you from a cardiology perspective? How does it impact your practice?
So we're very low risk tolerance. Obviously, if someone's having a heart attack, right, we're going to take every precaution to make sure we don't send that patient home. We really don't want to miss. We tell our patients, well, it's only 1 in 1,000. Well, we see 1,000 patients a week, so there's always going to be the 1 in 1,000. And so for us, even if our risk is low, we have a very, very, very high, very low risk tolerance to sending anyone home unless we're completely sure they're not going to have a heart attack. So what does that do? It leads to clogged ERs, overutilized expensive tests and CAT scans and nuclear stress tests. Cost a lot of money to operate. They're long lines backed up, and then financially they're really not viable for the hospital. And we would like to avoid sending patients for invasive procedures to rule out things that can be done non-invasively.
How does that impact from a cardiology perspective? What's the impact on you as a clinician, somebody who's trying to triage patients? What's the impact of this inflow from the ED and the relationship with the ED?
Well, it's something, signal to noise ratio, right? You're really trying to pick out the patients. The ED's got a hard job. They've got these patients coming in. They've got to make a decision. As we said, low risk tolerance. So when these patients come in and they come on our floor, we have limited resources of what we can do. So a lot of these technologies work, but they take time and money and effort. And so you have CT scans are a fixed resource. They aren't really that available and readily available for patients, so they have to wait. And especially on hospitals, often on weekends, for example, you may come in on a Friday at 3:00. This scan is not available to you until Monday, and that's unacceptable, honestly. Like in today's day and age, where we can't run hospitals as we call them as 5+2, which is 5 days a week and the 2 weekend days. They have to run as a 7-day hospital. So. But this is not acceptable. So we need to get to the patient's diagnosis faster.
It sounds like there's a lot of tension around sequence and resource. What is the sense of how many of those patients are truly acute in that gray zone? It's a number that I think I've heard argue about. Are we really missing on STEMIs? Is it really acceptable to wait 3-4 days? Or there are these rare cases where that patient didn't show the classic signs, didn't have the classic indicators, but there is something happening underneath?
Yeah, so the vast majority of these chest pain cases rule out and end up going home and don't require an intervention, a stent or bypass or medical therapy. The biggest thing that we have to differentiate from in a lot of these patients are what is the mechanism of a heart attack. And so when people hear heart attack, they feel like it's a blockage in the artery. Well, you can leak troponin, and troponin is the enzyme in the heart that we use to detect injury to cells. And that injury can come from a heart attack where you block blood flow to those cells, or from other forms of injury, or just stress. And so it's really hard for us to tell based on the troponin what is the actual underlying pathology that caused it. And so the majority of time, we're going to rule these patients out. But 100% agree, Tico. There's a lot of cases where the EKGs are normal, troponin may even be negative or very low, and all our other tests say, green, go home, this is probably low risk, but it turns out they do have a heart attack. And so we spend a lot of time trying to avoid those patients, and which is why we end up keeping patients longer, or we end up having all these complicated protocols to not miss anyone.
I appreciate your patient-centric logic. All of us hope that if we are in that situation, that there will be that extreme level of diligence. How did you know that Sandbox, when you partnered with the team, was focused on the right need? You've done some amazing research that you're now publishing on the technology that Sandbox is bringing forward, but tell me a little bit about how you connected the need to the solution.
So it's actually a funny story. So I met Jack back during COVID when him and Eric Schmidt were doing some really interesting work around monoclonal antibodies. And Jack had mentioned, everything that SandboxAQ was sort of going to become, and it mentioned about, he's going to have a device that's going to measure magnetic fields of the heart, and it's going to be revolutionary. And it was a concept. And COVID, we were busy with COVID. And then, a few years later, when Jack's like, hey, we have this device, and he showed me a picture of it, I was like, that's crazy. And I met the team, and it was real. And so I was like, wow, you guys went from this conceptual phase to actually building a prototype.
Your efforts have really been critical to steering the team to make sure we're focused on the right clinical need, to making sure the AI is structured in the right way to connect to clinical practice as opposed to science only or technology only. How do you see that role as the physician thought leader in developing technologies that are clinically meaningful?
Well, I think, you're spot on what's really important, right? And I think what we're really proud of in the studies that we've done with you is actually making it real world, right? Because we said, well, we got this great technology and it can read these really, really low frequency magnetic fields, and it's going to, well, how's it going to work in an emergency room? Or how's it going to work next to an elevator bank, or all these cell phones going off? Is that, is this something that's going to occur, in real time? And then that's one. What about real patients? Young, model patients, right? What about the real patients that we see with, different body shapes, habituses, different types of functionality? Remember, cardiac patients are sick. We're not talking about young, healthy people that jump up and can jump on a table. Can this technology really, really be functional there? And so before we even wanted to say, does this technology, work? We're like, can it work? Can we do this in a busy emergency room? And we did our first clinical trial of the discovery study, the MCG, in one of the busiest emergency rooms in New York City. All right, when you've got difficult logistics and moving around, then we were able to actually show that it worked, show that it was useful, show that it was sensitive and specific. So I think that was really exciting, rather than just patient in a lab. And so that was really where I said, wow, this thing actually clinically can apply, because it has the same form factor of other technology that we're using. It wasn't some big scan that we needed to have a big dedicated room on, right? So we had known about MCG for a long time, right? We studied it, and again, in cryo require Faraday cages, right? It just wasn't practical. It was a very cool concept, but the fact that we could have this passive device that's going to read the magnetic fields of the heart, that was really, revolutionary to me.
It's awesome, and I think one of the things that I heard you talking about was the comorbidities that patients have, and so this is actually, I think, a learning for the Sandbox team as well. Can you talk about the difference between wanting to detect coronary artery disease versus detecting ACS?
Yeah, so with the Sandbox team, and we've gone through with our team many, many times, Dr. Bott, like, this is a really overlapping area, which we really had to get right for these studies to make sense, right? So you have, when you talk about CAD, that's anatomy. Does the patient have a blockage, right? And then ACSs, are they having a heart attack? Are they having an event? Because you could have a 90% blockage in an artery, and some people could still actually run a marathon. They may be ischemic, but they're not having an event. And then other people can have a 60, 70% blockage. And at that moment, they're having a heart attack, meaning that there's a rupture of plaque, platelets, and now the patient's having not enough blood flow to that area, and they're leaking troponins. They're having an event. So, anatomy doesn't always define function or vice versa.
So it sounds like this is a frontier challenge in some ways, where the gold standards are not all integrated. So there's still new science in some respects to be delivered. Maybe we can take a moment to think about the future directions. Where do you see this technology going?
Yeah, so I think you have to understand what the fundamental shift is, and I spend a long time explaining to people, right? What do we have today, right, before this in terms of technology on the EKG? What's an EKG? An EKG is a summation of vectors that are coming from the heart, and so you're just looking at a one-dimensional view in each lead, and if you think about it, you're losing a lot of that information. So like maybe there's two signals and they cancel each other out. The revolutionary part to me as a cardiologist is the ability to create a 3D map of the heart, which EKG really can't do. People try to reconstruct from it, but you're not doing it. You're losing all that signal from the EKG because it's summative. And so having the MCG, which is a 90-degree magnetic field, 90-degree angle with all that spatial information, is something that we're just beginning to tap. And I right now, yes, we're focused on getting the ACS indication. And I think we're going to get it because I really think the technology really works. But I think what we're really just cutting the tip of the surface here. If we look at these maps and we're able to make these 3D, you take these dipole maps and these other variables that we're looking at and make these three-dimensional views, we're going to be able to actually see exactly where in the heart the signal is for the injury, right? Is it this much of the myocardium? And to make that 3D map, I think is something that really, will be revolutionary, to hold the heart in your hand and actually see where is the ischemia, is it ischemic? I think that's where we're going to be heading.
That sounds fascinating. Any last comments that you'd like to make?
No, I'm just really excited about continuing moving forward. And I think that, one of the things that I think is really exciting with Sandbox work, and I tried to pitch Jack with, was, what I found fascinating, the large quantitative model work that you guys are doing. And so, Kit, you and I have had multiple conversations about, heart flow, right, and CTFFR, and that technology is fascinating. And we're looking at, the fluid dynamics through that side. And I think Sandbox, really could move into that space as well, of being able to, create large quantitative models, model the physics of fluid dynamics in vessels through looking at CTs. And these are really expensive and high compute time studies that we do. And I think that's something that, really underappreciated what the, large quantitative models as a field can really do in healthcare, which is, simulating physics and allowing us to not just predict the next token of what we're doing, but to actually do that. So I think that's Sandbox team needs to get on that next once we're done. And as push Jack through many times, I really a believer that, as we keep getting the sensitivity of magnetic fields, getting rid of the noise, we move on to the brain, right? And I think that's really the most exciting frontier. Right now, we'll hunker down with the heart. I'll settle for like the best ACS detection and take us out of that 150-year-old technology. So keep working.
Thank you, Dr. Bender. We really appreciate you as an innovator, thought partner, investigator. You're really essential to this project, and thank you for joining us here today.
Thank you.